I'll just give a very quick introduction to who I am, so you know who it is that's standing up here. I'm a GP, literally retired from clinical practice last month. I've been a GP trainer. I've been playing around in informatics for about 20 years. I was chair of the EMIS National User Group. I spent several years working at the Information Centre. And I'm currently clinical lead for Patient Online at the Royal College of GPs. So I have responsibility for the editorial content of the toolkit. And I'm in the process of writing the last version of a guidance about how to use Patient Online for patient-centred care, and another piece about long-term conditions. And that's really interesting to me because that's where it's all heading. It's all about actually using technology around patient-centred care. And we've heard a lot about the benefits of people having access to their records in a way that they can use, and obviously online is a very, very useful way. And that overlaps hugely with this issue of information that we provide to people being accessible to them. I'm going to just talk through, because I think you in this room will have all the knowledge you need to implement this. So really what I really want to do is just try and pull that together and share it between us in no particular order, because there's no reason why you should start in any one position. But I think it's actually important to know for a practice which members of their practice population have got communication needs that need or would benefit from receiving information from the practice in a non-standard way. There's umpteen ways of doing it. The practice might be aware of 2 or 3 or be able to think of 2 or 3 people, but there will be a lot more that will benefit in one way or another. And I think we do need to be careful about wants and needs here. And we also have to remember that the Act, the law, says reasonable activities. In other words, practices should do things that are reasonable in terms of law. But basically what we're talking about is providing care that's centred on the needs of individuals. And we're just trying to do something for a group of patients that we haven't done the right thing for in the past. So, identifying patients. You can find codes in the record that might give you a clue about who may have special communication requirements. How easy do you think that's going to be? What sort of things would you look for in if you ran EMIS searches? How many of you here actually have experience of building searches yourselves? Because actually what we're doing is saying, we've got a new use for these codes. We never recorded these codes in the record so we could identify communication needs. It wasn't what we were thinking of. So some of it has got recorded almost by happenstance. But there'll be a lot of people where I looked through, did exactly what you did, then started to look through the patients. And somebody was put down as having visual loss because 20 years ago, as a child, they had a squint. Squint was dealt with surgically. No comment in the records ever since about whether there's any visual impairment or not. This was the set of searches that I got, which was like yourself. There were 2 patients with autism. I actually know of 3 patients with autism myself, as I just run the local MenCap group, and so I know who the people are, and we sort of expand somewhat into autism as well. Nobody deaf blind. Eye disease, this is 6,000 people over the age of 16, and with an eye disease diagnosis that raises the possibility, using codes, which actually you can't infer from a diagnosis very easily to visual disability, but we had 800 patients with a diagnosis that could imply visual impairment. We had, with hearing loss symptoms or hearing diagnoses, we had over 1,000 patients. Now there's possibly some overlap, but I think we're talking probably at least 1,500. That's a quarter of the practice have come out if you're just looking at diagnoses. But then if you start to look at hearing aids, for example, we came down to, where did I put it, hearing loss, 43 27 recorded with a registered visual impairment, registered blind or partially sighted. And when I actually started to define the codes as ones where there was a functional disability, they came out 100 patients, 105 patients. So what's reasonable for the practice to do? On the one hand, I've got a list of 105, and on the other hand, I've got a list of 1,500. So what would you do in response to those sort of numbers? And I think your practices may be higher or lower depending on how you've recorded data. And we've been sort of fairly obsessive about recording data for years and years and years. I think the reasonable thing personally is to write to those 100. But this is only one way of finding out who the patients are. When people come to the surgery, and if the receptionists, if the nurses, if the doctors are aware about something that they have never really thought about before, so this is an awareness, this is a practice culture thing, they can ask, they can infer that patients may benefit from something. And there's an awful lot of value, if you do nothing else, in just recording that significant requirement. And there are clear codes that cover most of it reasonably well. We've got a template which has got 10 codes in, which we think captures the vast majority of the services that we need to use for patients. And you can just use one template, 10 codes, that can transfer almost everywhere else. There are places you can put this sort of information in the registration details, but certainly for clinicians and for staff, adding this through a template is fine. In EMIS, Patient Online, if you use a template to add these codes, it puts it into a consultation, even if you're not actually doing a consultation, so it then appears online. Because interestingly, if you just use add a code in EMIS to add a code, that code does not appear online. Technically, I don't think, maybe somebody will disagree, EMIS actually meets our contractual requirements in that respect, but that's to do with the way EMIS works under the bonnet rather than anything else. So those codes are there. There's a letter, standard letter, which is one way of writing to people and just giving them boxes to tick. Unfortunately, you have to write to people in a standard way to get this information in the first place. If there are people that we already know will have problems, then perhaps we should be thinking about doing things another way. But we are where we are, and you have to be reasonable. When reports come in from hospitals and somebody has something in the letter that suggests there's a sensory impairment, is actually think, oh, actually, maybe we should be doing something about this, and you can contact that patient in whatever way seems best on a one-to-one basis. I'm not just thinking about how you deal with search results, but how do you contact people? Obviously, new registration of patients, quite important. Perhaps it should be part of the registration for Patient Online as well. I think that the message is you use just about everything you can, because not only are you having struggling to communicate with the patients, they're struggling to receive the communication in the first place. So use everything you can. One of the big things about Patient Online is that patients can see the recorded preferences that they've logged with their practice, and so they can then, as it stands at the moment, ask the practice to update their preferences. And it could be anything from communication needs to preferred place of death in a palliative care setting. Something that you again made me think about, Hugh, is that, and I did this some time ago when I worked with Age Concern, as it was then, to set up a patient transport system in our rural area where public transport was very poor and people had to come in from distant villages. And between us, we set up a transport service where volunteer drivers would drive people into the surgery who were able to come to the surgery but just couldn't get across the Yorkshire Dales to reach us. it may not be very easy for us because we're in a rural area and there aren't that many local established charity groups, but I would have thought in larger communities in towns, then practice working with local branches, local groups of charities representing people with disability is not a bad way to get the word out there. And that screen is just shows you that in registration details you can record things like the patient would like a large print letter, and there's also interpreter requirement and alternative correspondence format, which applies to braille and type and audio tape. Now, it strikes me that one of the problems with EMIS is that you can record stuff all over the place. Where's the most useful place to record it? And I think that depends on how you work. So I think the practice needs to work out for itself how it's going to do this. And it's not just a matter of the practice too, it's where does that data go to? If you're putting it straight into PDS and it was reconciling with PDS, then everybody would automatically have access to it. And that sort of thing has been talked about in terms of things like patients objecting to information going to care.data. Should it be on PDS? All these things could potentially be much more straightforward if they're kept in one place, but then you've got Big Brother building up with more and more data about you, so how do you do it? Applying alerts is, on the face of it, fairly easy. Worst thing about alerts is everybody just goes bang, get rid of it, don't even bother to read it. And alerts can be counterproductive. There are times when it's useful, booking an appointment. If there's an alert that says this patient would like to receive appointments by text and not on a written appointment card, that would remind the receptionist at the right time that that's what was needed. So configuring any kind of alert system so it only shows you the information when you need it about the patients it's related to, make it as automated as possible and only show it when it's really helpful, not all the time. Sharing the data. This is a potentially big issue. There's arguments about whether that data should be open because the unscheduled care never know what they're going to need to know, and then other people say, well, hang on a minute, you don't need to know about somebody's termination 40 years ago. There is a question about specifying this sort of what might be deemed to be admin data as opposed to clinical care, but actually it's data that supports clinical care, isn't it? So I think of it as clinical data. So if you're in an environment where you are going to be sharing data for direct care, then this is certainly the sort of data to think about putting into that shared data set. Consent. Consent's a major issue. It needs to be in your practice's publicity about what the data is used for. You've got to meet the fair processing requirements of the Data Protection Act. If it's for direct care, then there's an element of implied consent, but the data really should have a consent to view process going on. I don't want to get into IG too much, this isn't the place, but these are the sort of things to be thinking about when you actually start to share this data. If you're going to share it in other ways through summary care record, then all those sort of issues are thoroughly sorted. I honestly don't think there's anything that is worrying people. And then obviously you're sharing it with the patient. And then potentially you're sharing it with carers as well, because of what we call proxy access, which is something EMIS won't do at the moment. Again, it's a technical issue within EMIS, but basically, if you've got a parent who wants access to their child's record, you can give them a login password, which is located in the child's record. But the ideal situation is that that parent has an identifiable, that individual parent has an identifiable login related to them to the child's record. And so if you've got carers, if you've got a husband and wife carer, if you've got a daughter and parent or a son carer, that individual who's the carer should have a separate identifiable login. It's more secure and you can switch it off and you can restrict access to the key bits that the patient wants instead of, as in EMIS, if you share password, then you get access. The carer gets access to everything. So again, there's issues about sharing, and then I probably don't need to talk too much about accessible information. How many of you here use texting to patients? There's a variety of ways of doing it. There's the sort of automated texting to remind people about appointments. And then there's actively texting people, so sending out the appointment. You know, I'm not going to give you a card, I'll text you. It can be part of a process, can't it? I know somebody who did a very good master's looking at extending the effect of a weight losing campaign. She's a dietitian, and she did a standard 6-week weight loss course with people, and then she randomized people after that to carry on with texting for 6 weeks or no further contact. And the 12-week end result was much better in those where she just texted them and said, are you sticking to your 5 a day? Are you having breakfast? Are you doing 5,000 paces? Yes, fine. And they did better. Simple. Texting is something that I think we generally don't use well enough. That's a very quick run through of some of the issues as I see it. Are there any questions or any comments? Yeah. Do you mind, the codes I picked all came out of a set that EMIS gave me, Jonathan Meadows' set. I mean, EMIS devised the full set, and I've just picked 10 of the key ones for our purposes, but there's about 30 other codes in a set, and if they're on the Sports Centre, we perhaps have a word, if that's any help. Yes, but only just. I was at a meeting at CQC about 10 days ago, and they are looking to develop a set of standards around digital healthcare for primary care providers. And so this was an exploratory meeting, and I was there to represent RCGP. And there's something called the Professional Record Standards Board, which is a relatively new organisation, which is about doing exactly what we're talking about, setting professional standards. CQC are aware. There's all sorts of things, from Skype consultations to email to texting. There are lots of issues. Health apps, real problem with health libraries and which apps are recommendable and which aren't. And they want to try and tidy this up. So yes, they know it's needed, but I don't think they feel they've got the criteria against which to test it, other than with this standard. The standard exists because the document's there, and so they know they can test against it and can say, what are you doing to meet this standard? That's relatively easy. Probably that they've got enough to actually raise that with a practice, but when or in what level it's become part of a standard assessment, I can't say. I think if somebody's not shown any interest in it at all, that would be fairly easy for CQC to criticise, wouldn't it? But if you're doing what you can, and if there is evidence that practices are working in a federated way in some way to achieve some of the extra things, then that's a bonus. And yeah, that last slide really is just say you've got to communicate with people in the language, in the broadest sense of the word, that they use. Simple as that.